I'm here to mostly talk about some of the impact that we're having. We have put out 3 community indicator reports since 2003. We bring it down to good quality neighborhood level data. It all started with our early development instrument in the EDI back in 2003. Then Halton designed the kindergarten parent survey, which is the sister survey to the EDI. So we do that now. That's been passed on to the province, and many communities do that now. And we also did the Halton Youth Survey. We designed that as well for all the grade 7s and all the grade 10s. So we can now actually break our data down into lots of different health equity kinds of questions now. And I know our epidemiologist at our health department frequently uses this information. We can tell you by income what the breakdown is about use of libraries, for instance, and who gets the flu shot, who gets you name it, who's involved in sport and rec programs, who's involved in community volunteerism. These are the kinds of questions and robust data sets that we have. We moved into more of an interactive data mapping system now. So we now have a data portal. Our data portal is not any more excellent or than most other data portals that you would go to, right? But it has all of our data available. It maps it by our 21 neighborhoods that we have in Halton. We thought that was a really great feature. But one of the things our data portal has that I have not seen in anybody else's except that uses the same vendor is it allows the user to upload their own client data into it and map it over top of our population data. All right, so if you know how to create an Excel spreadsheet and you know how to copy and paste, you are now a GIS specialist on our data portal. And that has been remarkable advancement to the work in terms of knowledge mobilization, allowing people like you in this room to actually create meaning and tell a story with your data is incredible impact that's having. We have one story of the town of Milton Parks and Rec. So when somebody comes and we bring them into our training program we ask them to bring some data with them in an Excel spreadsheet format so we can show them how to do this. Well, the town of Milton brought, their Parks and Rec department had an after-school program targeted for low-income families. They mapped the data at our training session, and not one of those kids came from a low-income area. They investigated further and confirmed that not one of those kids were from a low-income family. They switched up their registration formats and now can confirm that they're all from low-income, and it's meant for the population that it's meant for.
For us, it's been interesting because we are a systems approach body. We do a partnership assessment survey, so that really looks at what's the difference we are making in the work that you do. How are we enhancing the work that you do? And as a result of our involvement with your work, what has changed and what has remained the same. So it's interesting to do that because they're lengthy processes, but we need to have some establishment of how that changes over time. And so I think that we have to be brave to do it too, because sometimes you don't get the responses that you want.
And as soon as you go to services and you say you're a mood and anxiety service, and in the mood and anxiety service, for some reason, it seems like though 2/3 of people with depression are women and 1/3 are men, in your service, somehow, there are more men than women. Okay, so that's what they were told. So we went back to them and we said, you've got to do something about this. And for 1 year, there was a key performance indicator at the sort of CAMH level, which was trying to increase the number of women that come through the mood and anxiety services to 50%. So it was at least 50-50. And at the end of the year, that happened. And so there are now more women being seen in the mood and anxiety services at CAMH than men. So that's what happened. The problem is we have no idea what they did. okay? Because the health equity department at CAMH is a few people. And what we say is fix it, get on with it, do it. But we don't stand there and sort of say exactly what they did. We just say, you know, you need to move forward. There were a whole bunch of things and a whole bunch of things that could have happened. Say, for instance, they talked about trying to change the hours of the day so it's more woman-friendly, trying to get some female security guards on site because that was an issue. There are loads of things they said they might do. Sorry? And trauma-informed care was the other thing. So Branka actually knows what happened, it sounds like. Branka works with me, and she's the manager of health equity at CAMH.
We have two very distinct points at which we collect data at the onboarding process. And that onboarding process really enables us to collect the salient socio-demographic data that informs our program. And the second formal point where we collect data is through our client satisfaction survey. Because what the client satisfaction survey tells us is whether the service plan or the intervention we've provided, whether it's effective or not effective. So in terms of the onboarding process, the data that we collect and how that informs the service plans in terms of culture, in terms of gender, in terms of socioeconomics, in terms of language, in terms of sexual orientation, all of these elements we've been able to address because we've had that data from the client and their family. So we're able to address that. Let's take, for example, from a language perspective. Knowing that we serve a really diverse population has also influenced our hiring patterns. So we try to hire staff that are as diverse as our population. So when we have a client who speaks a particular language, or even more at a micro level, a particular dialect, we can then look through our staff list in terms of who speaks a dialect and match that client with that staff. So in terms of language, we're then able to provide services to that client in a way that we can deliver quality in that the client can speak directly with that staff. And even if the staff is not working on a specific shift or day, recognizing that there's someone in the organization that they know who speaks that language, that if there are any issues, then we can link the staff back to that client.
At the LHIN, we see, other than our strong supporters who started off really believing in the equity data collection, we're seeing more and more providers getting excited about the data and moving from saying the LHIN asked us to collect this data to, we're collecting it because it's helpful to us. Mm-hmm. And they're getting excited by the data they're actually seeing. Just the being able to profile their patients they're seeing and saying, okay, we're seeing patients from this many, this many come from this particular ethnic group, or this they speak these languages. Like, it's been very exciting for providers, and they're sharing this information with us, and that's really been one of the great things. There's a real move towards equity, and when they start to link the client demographics to outcomes such as length of stay in the ED or alternative level of care, who's having longer LC than others, they see interesting patterns which then make them ask more questions about what can be causing this. Is it because maybe a particular ethnic group doesn't have maybe enough supports in the community. So what can we do about that? So it's been really exciting journey.